We've heard a great deal at this meeting about the progress that's been made in taking care of younger, healthier myeloma patients, but I think those of us in clinical practice realize that there's a large unmet need in dealing with our older, more frail population. And at this meeting, there have been two interesting papers presented, one from Dr. A.J. Chari from New York and one from Dr. LaRocca, the Forte trial in Italy, that address this challenging group of patients. In the first paper by Dr. Chari, it involved a large database analysis that was able to assess time to next treatment rather than the details of overall response, etc., in populations with various definitions of frailty, ranging from age to performance status, etc. And they looked at two commonly used regimens in the U.S., VRD and RD in older patients. And they looked at the pattern of usage, and not surprisingly, the VD patients had more renal insufficiency, were a bit older. But the bottom line was the patients who received VRD had a markedly improved time to next treatment, regardless of how they did the data cuts. And I think it emphasizes the efficacy of the role of this particular regimen. And in this real-world data, their outcomes for time to next treatment certainly were 3 years or more, which was almost double in some groups that which was seen with VD. So I think it emphasizes the potential role of that regimen in older patients, if at all possible. The second trial has been presented before, but looked at RD given conventionally until progression versus a regimen in which 9 cycles were given, and then the dexamethasone was dropped and the Revlimid dose was reduced to a more maintenance-like dose of 10 milligrams a day and continued. And these were in patients that were elderly. And not surprisingly, the patients who were on the modified group that cut down to maintenance and dropped the steroids had a comparable progression-free survival at 18 months, and certainly much fewer dose reductions, much less discontinuation of the Revlimid, much less neutropenia. I think this confirms what a number of myeloma physicians in Canada have already learned, is that you can get more mileage out of the RD regimen if you don't push the dose starting at 25 milligrams a day and milk it for all it's worth using lower doses with a better toxicity profile. And I think in polling informally my colleagues, we generally always start at a lower dose, and that's a bit different strategy from starting at 25 milligrams of Revlimid and then automatically reducing after 9 cycles to 10. Ours is more starting at 10 or 15 and continuing that. So I think we've already realized that you don't need the maximally tolerated dose in these elderly patients to get a good benefit, and certainly a better toxicity profile and patient tolerance. The other aspect of this paper that I find reassuring, because I had not been doing it routinely in my practice until this paper came out, is feeling reassured that you can drop the steroids. That wasn't done in the first trial, but it was done in this trial without loss of efficacy, and certainly that will be an advantage for our patients who routinely and consistently really dislike taking long-term steroids. And of course, it has detrimental effects as well.